Like the distal femur, the tibial plateau is covered in articular cartilage. We'll discuss the structure and makeup of this cartilage in a minute. The menisci, two large fibrocartilage structures between the femoral condyles and the tibial plateau, serve to provide congruency between the relatively flat tibia and rounded condyles of the femur. To this point, both the medial and lateral menisci have a triangular shape in cross-section, with the tall, broad profile at the capsular border tapering to a thin point in the central portion of the compartment. The fibers of the menisci are oriented in both a circumferential and radial fashion. This helps to resist compressive and shear forces. Healthy menisci will accommodate and distribute the forces placed upon the knee. This normal function is chondroprotective. The medial side of the tibia is concave to accept the more distal projecting medial femoral condyle. The lateral side of the tibial plateau is more flat, almost to the point of a slight convexity, in order to articulate properly with the flat and more proximal lateral femoral condyle. The more specific and pertinent anatomy of the knee with regards to arthritis is the cartilage that covers the articular surfaces of the medial and lateral femoral condyles, proximal tibial plateau, and the undersurface of the patella. Pertinent anatomy also includes the subchondral bone as the other important structure, as conditions affecting the bone can ultimately lead to cartilage injury and progressive breakdown or erosion. Articular cartilage, covering the distal femur, tibial plateau, and the undersurface of the patella, is a highly specialized connective tissue that lines all of the articular joint surfaces of the body. Its primary function is to provide a smooth surface for load transmission with a low frictional resistance. There is a complex interaction between the cartilage surfaces on the opposing sides of the knee joint. In its normal healthy state, articular cartilage functions to provide a smooth, low-friction surface that manages the extreme forces to which the knee is exposed. When the articular cartilage is damaged or suffers from degenerative disease, that function is impaired or lost altogether. Articular cartilage has 4 distinct layers. These layers, or zones, start with the articular surface called the superficial zone and move deeper through the transitional, radial, and osseous zones. These different zones each have unique characteristics that contribute to overall cartilage function. The superficial zone has several characteristics. It is the level with the highest content of collagen and the lowest content of proteoglycan. Collagen is the main protein that makes up the structure of the cartilage extracellular matrix, and proteoglycans are the proteins that bind the extracellular matrix together. Further, the superficial layer produces lubricin, a protein that coats the cartilage and acts as a lubricant. The lubricin coating is sometimes referred to as a boundary lubricant for the articular surface of the cartilage. Finally, cartilage progenitor cells can be found in the superficial zone. Cell orientation differs between the various layers of cartilage, and the collagen fibers in the superficial zone are flat and oriented parallel to the joint surface to limit friction. Moving deeper into the transitional layer, these cells are more rounded, and the supporting collagen fibers appear more oblique as they transition from being more parallel to the surface of the cartilage toward being more vertical or perpendicular to the joint surface. This structure directly beneath the superficial zone provides protection against the shear forces of the joint, while the changing orientation of the collagen provides initial cushion to axial loading. Even deeper, the transitional layer blends into the radial zone. In the radial zone, collagen is perpendicular to the joint surface. There is a reduction of the collagen content, and proteoglycan continues to increase from this superficial zone. This layer provides the most resistance to compressive forces. The bottom or lowest layer is the osseous zone, also known as the calcific layer. As the cartilage transitions to this point, the cells begin to calcify. There is an identifiable tide mark that separates the deep layer of cartilage from the calcified cartilage below. The pink-stained cartilage in this image has a visible tide mark line between the radial and osseous zones. The subchondral bone consists of the tide mark where the deep articular cartilage layer transitions into a thin layer of cartilage and, below that, the subchondral bone plate. Beneath these layers is a thin layer of spongy cancellous bone referred to as the subarticular spongiosa. It is from this layer that nutrients and oxygen are supplied to the subchondral bone. The blood flow in the subchondral bone is greater, as much as 3 to 10 times higher than normal trabecular bone. This increased perfusion allows for approximately 50% of the glucose, oxygen, and water requirements for the deep layer of articular cartilage. Finally, there is an interaction between the calcified cartilage and the subchondral bone plate. This plate possesses an irregular surface to which the articular cartilage is keyed in. This fit is what binds the cartilage to bone. Despite the blood flow from beneath and nourishment from the synovium, throughout these 4 layers, the cartilage is avascular and aneural in nature, meaning there is limited blood and nerve supply to the cartilage itself. The diffuse nature of the chondrocytes in the cartilage matrix and the near lack of cell division severely limit the ability to repair or replace injured cells through regeneration without outside intervention. Blood in the knee joint is supplied by a network of 5 arteries. The genicular arteries make up this group of 5 and include the superior medial, superior lateral, posterior or middle, inferior medial, and inferior lateral geniculars. Contributions also come from the descending genicular arteries and from the anterior tibial recurrent artery. Each vessel serves a specific area, but the collection of vessels form anastomoses around the knee joint. Untreated injury to the superficial layer of cartilage can lead to degeneration and progression into a full-thickness injury. Full-thickness traumatic injuries will also progress if not treated. Injury to subchondral bone due to trauma, either acute or repetitive microtrauma, or due to vascular compromise for any other reason, will also lead to full-thickness cartilage damage.